Well, we might as well get started. Thanks for joining us at the lunch hour today. My name is Rob Reed, and I'm one of the co-leads for RISE with John Lavis and Jeremy Grimshaw. And this is the first regional session that we're holding for teams in development and discovery. So we've got about an hour to share with you. We'll hold some time for questions and a discussion, but we really do want to go through a little bit of material for you to kind of help advance thinking and practicalities around moving towards Ontario Health Teams. So if those of you, I think some of you may have been on the webinar on Wednesday that John talked about RISE and the program and the supports that are built into RISE to help teams at any point in their OHT journeys. So we'll go through a little bit of that today. And when John talked about it, there are a variety of building blocks that are built into RISE that can really help you move forward. And John's going to spend a little bit more time in a few minutes talking about it today. We've selected to kind of have 5 really brief presentations today on key aspects around those building blocks to move towards Ontario Health Teams that can really, we believe, where you might benefit from some resources and support in these areas. So John and I are going to be tag teaming today. And just as a couple points to begin with. First, these topics and everything about Ontario Health Teams is actually pretty complex. And so today is really a briefing, and it's making sure that we're anchoring with some of the core concepts and core things that people need to think about in their early journeys on Ontario Health Teams. We'll be having weekly seminars and more events and more resources to help teams as they move through this in the future. Second is that we're only talking about these 5 topics today. There's a variety of other resources on the RISE website that might be applicable to you right now as you think through the development of in the Ontario Health Team landscape. And if there's things that aren't on the RISE website that you particularly would find helpful, please do reach out and we'll see what resources we can put to bear to help with that as well. Third is that we realize that some of you actually might be advanced in your thinking before what I'm talking about today. So please do share your experiences in the discussions around what your learnings are or what you'd like to share around the topics today. And lastly, I just really want to emphasize that the opinions and what John and I are going to talk about today are really our own thoughts and our own opinions. We don't reflect we're not speaking on behalf of the ministry, particularly around policy questions or around the application, that process. If you have questions around those issues around the specific application or policy relevant questions, please direct those questions to your ministry contact. So is there any questions on the agenda today? If not, we'll just kind of move into the next phase. I just wanted to quickly introduce ourselves. I'm Rob Reed. I'm the Chief Scientist at Trillium Health Partners, the large hospital institute in Mississauga. And I'm joined today by John Lavis, who's a professor at McMaster. And we're, in addition to Jeremy Grimshaw from Ottawa, are leading the RISE platform. We've also got Carrie and Kaylin in attendance today. And we wanted to give a real nice shout out to Donna and Sick Kids and OCHSU for providing the venue today for us to be here on very short notice. And then we have Karen from the ministry and a variety of other people on the phone as well. Okay. So, John, can I turn it over to you, and you can just give a walkthrough about Ontario Health Teams 101.
Absolutely. Yep. Thanks very much, Rob. So for each of these presentations, there's typically one or more RISE briefs. So the most relevant one here is RISE brief number 1. So Ontario Health Teams, if you're part of a team in development or in discovery, you probably know that this is a very new way of organizing and delivering care. And it's new in many respects. One is it brings together all providers. Certainly at this stage, home and community care primary care and acute care providers should be at the table, but at maturity, the expectation is that it would be the full continuum of care. Second thing that's different is that they're all working together in a very coordinated team. And the third thing is that they're all working towards a shared goal. So in the past, we've often, as organizations, focused on goals that are specific to our niche. The future is about agreeing on a set of shared goals that we're all collectively working towards. And the general banner under which those goals fall is the quadruple aim: improving care experiences, improving health outcomes, keeping costs manageable, and keeping providers satisfied and engaged. How that plays out in year one in terms of the particular metrics that teams would be looking to try to move the needle for, that in year one is going to be up to the team. So that's part of what the application process will force you to do when you get to that stage. Ontario Health Teams will be clinically and fiscally accountable for delivering a full and coordinated continuum of care to a defined population. So again, big change from what you're used to. To me, this is the most exciting transformation our health system has ever gone through, and a tremendously exciting opportunity to make a real difference in the lives of patients, families, and caregivers. None of us know how to do this. There's pieces of it that are completely new to the Ontario context. There's pieces of it that some sectors know how to do and others yet don't. All of us bring different assets to the table, and the key is that we find ways so we can learn from one another, and we find ways to hear about when people have had successes that others can use or adapt. But we also need to learn from where things haven't gone well and what the lessons learned from that are. As part of the ministry's central program of supports, RISE is going to provide support for rapid learning by teams. I've got a couple of little glitches on this slide. The first point is correct. 31 teams are going forward to full application. That application is due on the 9th of October. The 41 teams are 41 teams in development, and then there are a number of teams that are in discovery. And then there are teams exploring innovative models. These might be teams that represent a provincial or a regional asset, and the ministry is interested in them exploring how do they intersect with Ontario Health Teams. So if you're a provider that runs a provincial program of some type, and you run a variety of regional programs that would cut across OHTs, plus you're a local provider, how do you intersect with the OHT landscape? So that's partly what the innovative models will be exploring, and then in future that will inform how OHTs intersect with those regional and provincial assets. If you haven't seen the Ontario Medical Association map, it's a really great way to find out who else is out there at a similar stage of development. So the green dots are the teams invited to full application. And unfortunately, the red dots, because red suggests no, but I would interpret the message to in-development teams, go, just keep going. It might be that you're not doing the application for October 9th, but the hope is you're moving forward onto the next stage in your developmental trajectory. You can zero in on particular pieces of the map. You can see who is working in what has historically been a LHIN region. The ministry's original guidance document, which was an incredibly thoughtful, very well constructed articulation of the kind of future that it hopes all teams will get to. There were 8 readiness criteria, which you would be familiar with if you were involved in a team during that process. We use the term OHT building blocks because we see these as being the way to build up to a team that is capable of moving the needle in the areas that really matter. We've made some changes to the ordering in the building blocks, some minor adjustments in wording, but that first column should be familiar to all of you, but we call them the OHT building blocks. We then went through the ministry document and we identified all of the areas in the descriptions of where teams would need to be at maturity, where teams would need to make strategic choices over time. And we came up with 58 unique domains. The middle column is an expansion of building block 4. That's the integrated care building block where you're trying to improve patient care and experience. So we've identified 18 domains where teams would need to make strategic choices in order to deliver improvements in patient care and experience. If you then go to the final column, what we've done is we've mapped from the building block to the OHT full application. So none of you need to be worried about this for October 9th, but you should all be very attentive to that next stage that you will move into, which is the full application. So you might want to look ahead at the application, but rest assured, all of the thinking that you did on the readiness criteria still appear again at the next stage, but the ministry is asking for more elaboration in very precise areas. We've sat in on many ministry webinars and tried to learn as best we can what some of the common opportunities for improvement are among teams. And so I've got 2 slides that will give you our read on where there are opportunities for improvement. So the first one is a defined target population. So as you move forward on the developmental trajectory, you'll need to be able to very clearly define a target population, and that needs to be something that can be well justified in terms of demographics, cost drivers, barriers to equitable care, but probably the most important one is the referral and utilization patterns. So every team will eventually end up with what's called an attributed population. So those are individuals who currently receive care by providers in the area that you anticipate covering. If you're not familiar with this language, you'll find on the RISE website a document that lays out the original methods that were developed by the Institute for Clinical Evaluative Sciences to do this. Currently, there are about 75 to 80 of these naturally occurring networks. Those are logical groupings around which Ontario health teams would then build. So it's important to keep that in mind, that you'll need to be able to justify your choice of your defined population with respect to those referral and utilization patterns. Second, full continuum of in-scope services. So this is now moving from building block 1 to 2. Some of the applications that came forward might have been very strong on home and community care, might have been very strong on acute care, some might have been strong on primary care, but remember that eventually every team needs to get to the full continuum of care. And at this stage, the absolutely essential sectors are home and community care, primary care, and acute care. So all of them need to be represented at the team table. Third, patient partnership and community engagement. Patient partnership is often an area of strength for many organizations in the Ontario health system. It's been an area of focus for the last decade, but the ministry is particularly interested in community engagement to make sure diverse voices are being heard, and it wants to see a very precise approach to how you are dealing with community engagement, in particular with Francophone populations and where relevant with Indigenous communities. 3 other areas that are opportunities for improvement. The first one is true of virtually every team. The biggest change in how we think about delivering healthcare in the province being ushered in by OH teams is a move to population health management. There are other countries in the world that have done very, very superb work in this area, and we have Rob Reed, who's part of RISE, who has brought his learnings from the US to this, and Rob's going to speak about this in more detail, so I won't go into it. But keep in mind that as you move forward as a team, you have to be able to think about how you are going to engage in population health management, and that includes in the early period focusing on groups of patients for whom the quadruple aim metrics are particularly poor, and then the other stages Rob will get into. Fifth area for improvement, digital health enhancements. So alongside Ontario health teams, the government is using this as an extraordinary opportunity to take Ontario from where it is with digital health and move it to where it needs to be. We can do our banking, all kinds of stuff online. Within a few years, we need to be able to do many, many, many more things digitally than we currently do. So you need to be thinking about how are you going to introduce those enhancements, and where they exist, move them from pilots that might reach 5,000 patients to full scale where you reach every patient for which you're accountable. The final area that represents an opportunity for improvement is leadership, accountability, and governance. So some teams that came forward hadn't quite worked out the leadership infrastructure. Who's sitting around the table? How are you making decisions about this? How have you decided to engage patients in that leadership infrastructure? Where are the primary care providers? Others had got to that stage, but hadn't quite got the full array of primary care capacity and partnerships in place. And they may not have started to take steps towards what we'll call collaborative governance. But I'm going to come back to those points. The ones that are underlined are ones that I'm going to return to in some later slides. So the next agenda item is defining a population and in-scope services. So I'm going to be very brief. I just have the one slide on this one, and I've alluded to the key messages already. But it's very important as you take the next step as a team to understand the referral and utilization patterns within which your team is having to intersect. So the ministry has not said you are going to be accountable for a geographic unit. If you're sitting in a city like Hamilton, you have to be aware of the fact that people come to the primary care providers within your city boundaries from a lot of adjacent areas. And some of your citizens actually commute into Toronto or commute to Mississauga for work, and they might have primary care providers in those other communities. And the idea is that these teams align with how patients and families currently use healthcare and how providers refer you to other providers. So it's very important to optimize that match so you are aligned between what your focus is and what those utilization and referral patterns are. And then although you're not going to know who all these people are, you're not going to know exactly which ones are going to Mississauga for primary care, you need to focus initially on the biggest group, which are the folks that are rostered with a primary care physician or provider in that area that you have chosen to give focus to. On average, that means about 82% of the patients within that referral and utilization network. Another point about this, plan for the full continuum of in-scope services, so moving from population to in-scope services. So I mentioned before, a lot of teams came forward with really great partners for pieces of this, but the ministry is really looking for really great partners on home and community care, great partners on primary care, great partners on acute, and then the more you're able to extend beyond that, the better. But those are kind of the minimum ways in. So I'll now move on to, I'm going to pass it to Rob to talk about population health management. I alluded to the fact that this is the newest area. I've gone from knowing -5 on a scale of 1 to 100 about this to maybe 20. Rob knows a lot about it because of his experience in the U.S. This is covered in RISE Briefs 6, 8, and 9. And if you're just coming to terms with it, or if you understand it but you want to have a handout for other members of your team, each of those RISE Briefs links to a 2-page summary sheet that might be helpful as a handout.
Yeah. Thanks, John. John is quite correct. This is a dramatic transformation for healthcare in Ontario. What's vision out of the Ontario health teams? And a central component of it is really, really reshaping the care delivery system to make sure that there's smooth transitions between care units, to make sure that no one's left behind, and that they're actually provide a real ability to take accountability for the full population. What's really important in the concept underlying population health management is the idea about populations, okay? It really is. Population health management refers to the proactive management of health and healthcare in defined populations. And underpinning, it's just, this isn't on the slide, but I want to just anchor on a couple concepts on here on population health management, what this really means. So we've talked about populations. What does that really mean? It means that you're not only focusing on the people that come in the door, but you're also focusing on the people that don't, okay? Full population coverage, regardless of their current utilization patterns, okay? That's really essential. And then, so it's about knowing who your entire population is and about what their needs are, okay? That's critical. Second is it's the concept of being proactive and planful, okay? Not just reactive, but planning care proactively. And it's about proactively filling care gaps, proactively connecting and coordinating care, proactively reaching out for people who've fallen between the cracks and haven't and are lost. Third, it's about addressing health inequities, okay, that relate to socioeconomic determinants of care, and it really relates to removing those barriers to care. Okay? And then finally, and probably the most important, is it really relates to being patient-centered and not disease-oriented. It's really addressing the full complement of problems or issues that patients have when they present at any time in the health system, rather than picking bit by bit as we go through it. Okay? And it's really about engaging people in their health, and rolling it up to the population level. Okay? So, in simple words, it's about proactively getting the right care to the right person at the right time across a full population. Okay? Now, that's easy to say, hard to do, extraordinarily hard to do, to think about actually how you might do that. Okay? So these are a few of the first steps to getting on the way. The first is really to think about the full population, and John is absolutely entirely right. We have to actually think about population in different ways now and think about an attributed population. So I do encourage you to read those documents, because we actually have to define our population based on current patterns of care rather than based on geography. That is the usual modus operandi here. But once we actually settle on the population, then it's really focusing on where the efforts for the OHTs in their early development are going to reside. We can't focus on the entire population to start with, so we have to actually segment the population into specific groups of people that have like needs, okay? And then figure out for those segments about how we can realistically reinvent care pathways for patients, and then gain some momentum, and then spread it across different populations to the full population. Okay, that's what that's about. And the ministry has given lots of leeway for OHTs to decide on where they start. What are the subpopulations on which they start? And OHTs have to make choices on that based on opportunities, based on opportunity for improvement, based on feasibility, based on the partnerships, to make sure that you've got the full partnerships that you need at the table to do that. Now, once you figure that out, then the next step is really around redesigning the care. And when it takes a real different thinking around designing care from a population frame. It's really making sure that you're actually thinking about everybody and thinking about care proactively rather than in a reactive mode. And when I was in the U.S., we talked a lot about designing care pathways that had both in-reach and outreach components to facilitate population-based management. And I find that notion quite useful now, and I just want to share it with you a little bit. In-reach is about addressing quality care gaps or coordination of care needs or that sort of thing at any time a patient touches the system and the partners of care. So if a person goes to a hospital-based specialty care unit for diabetes care, that they should be prompted around the need for preventive care, around flu vaccination, and the needs for mammography and so forth. Okay? Outreach is about tracking planned care activities and making sure that they actually happen in a planful way across whether the segment is preventive care, acute chronic illness care, rehabilitative care, palliative care. Whatever the OHT is selecting in terms of its care pathways, it's really around proactively reaching out around those care pathways. Okay? And then the tools to do this are actually also important. We need care pathways that are well articulated across members. We need guidelines. We need coordination of care tools. We need care coordination mechanisms and so forth. And later on in these RISE briefings, we'll be giving more explanation of the tools that can facilitate population health management. This is particularly where the role of technology can apply, and particularly the new digital health strategy is that outreach mechanisms may be particularly advantageous with digital technology than we've had before. Okay. I'm going to skip this slide, and then I really just want to talk about data and analytics. Population health and management is really around tracking people and monitoring them, okay, to make sure that we're bringing them in and we're making sure we're delivering care proactively at the right time. And that's very dependent on measurement and very dependent on tracking. And so we need really sophisticated measurement and analytics tools to be able to allow for that. We've got to be able to track those problems, and then we've got to, over time, we actually have to see whether things are working or not. And then if they're not working, we identify what the problems are and fix them. These are some principles, and I'm not going to read through with you right now, but there are some reasonable principles that have come up that groups have formed here that really talk about some of the guiding principles that could help move our thinking into a population health framework. Remember, it's always population-based, it's always person-centered, okay, in terms of the care delivery. But it's focusing on care experiences and health outcomes. It's making sure that we're drawing across the OHT partners. It's talking about new roles and responsibilities for different partners at different parts of this population health management strategy, and so forth. So I'm going to end it there, John, and then I'm going to actually turn the rest over to you.
Thanks. And Rob encouraged you at the beginning to be thinking about experiences that you've had that you want to share. I'd also encourage you to be thinking now about questions that you want to ask. And there are no stupid questions. We're all feeling our way through this together, so I'd really encourage you to be ready with some questions that are particularly relevant to the issues your team is working through. I'm just going to switch gears and go back to that building block around leadership, governance, and accountability. There are 3 RISE briefs that speak to this, RISE Brief 2, 3, and 4, so they're all sitting on the website and available to you. Depending on where you are as a team, this one may be the most important, or it may be one that you've already got well in hand. But there were teams that came forward that hadn't yet put in place a leadership infrastructure for how this was going to work. So I'm just going to give you an example. There was a group that followed 5 teams, albeit over a longer trajectory. They'd been kind of going down this path anyway, and then the OHT opportunity came along, and then it allowed them to move through the remaining steps quickly. But we borrowed from that to draw some insights together about leadership infrastructure. Every team needs to design the right infrastructure for them. This is just to get you thinking if you haven't nailed this down. One piece of it might be an executive leadership group comprising the CEOs and the executive directors of the partner organizations. They're not going to be involved in the nitty-gritty stuff, but they are going to be absolutely essential to make sure they are okay with the overall strategy, and that they bring their boards along through the process, so the boards are not surprised when plans come forward. Second is an integrated operational management group comprising vice presidents of operations, directors of programs, and so on. These are going to be the people that really get their hands dirty, looking at the segmented populations, thinking about how to co-design services, and so on. And then many groups have set up, many teams, I should say, have set up working groups focused on particular priorities. So some examples would be a working group focused on primary care leadership and engagement, another one on community engagement. The full application requires you to answer a number of questions about home care, so some teams have that. Their digital health is a building block of an Ontario health team, so some people have a working group focused on that. And some teams also have a working group focused on communications because citizens start to hear about this stuff and they want to know what's happening, and you might want to be proactively communicating with them. Work plans are also key. What are all the steps that need to be taken? So given where you currently are, if you are a team in development, what do you need now to be doing to be laying the groundwork, so creating these building blocks? And you need to be thinking now about your attributed population, and you need to be thinking about what subpopulations are you going to focus on in year one once you get through the application process? So don't slow down the work that you've done. Keep working on it, and the work plans will help to drive that work. If you already have the leadership infrastructure in place, then one of the big challenges that many teams face, and this is true of many teams invited to full application, is how do you support primary care leadership and engagement? An area that many teams, including teams that were invited to full application, recognized that they needed to do more in was getting primary care at the table. It's very hard. Sometimes you can bring a big family health team together, but there's still people in other models. There's all the independent providers. How do you engage them? So in the RISE brief on this topic, we offered 3 bits of advice. One is in terms of helping the full diversity of primary care providers understand what this is about. Think about promoting the outreach effort of groups that already have well-established relationships with the different types of providers. So you'll probably recognize a lot of the acronyms. I won't go through them, but family physicians, the medical association in general, nurse practitioners, registered nurses, folks working in CHCs, folks working in family health teams, they all have their associations. They're all trying to help primary care providers understand what this means, encourage providers in your community to take advantage of those assets. Second, support primary care providers to become leaders in their team and help shape it. We're aware of at least 3 initiatives out there that can help primary care leaders in your community. One is the OCFP's Leadership in Primary Care Network. If you have local primary care folks who you see taking on leadership roles or who you would like to see take on leadership roles, encourage them to join the network. The Ontario Medical Association is trying to connect up leaders, physician leaders, who want to play a big role in OHTs. So they might be able to say, hey, you're in Peterborough, there's someone from is it Campbellford that's nearby? I should know this, I used to work there. Campbellford? Anyway, another community nearby, someone else doing exactly the same thing, you two should be speaking to each other. And then there's also the, Association of Family Health Teams of Ontario, Ontario College of Family Physicians Primary Care Virtual Community. So for primary care docs, they might want to be using that platform to be communicating with one another. So there are places that you can point your primary care leaders to so that they can interact with their peers and discuss the leadership challenges they're facing. Third, you can work with these primary care providers, these primary care leaders, to encourage the active participation of as many primary care providers as possible in your team. And similar to Mike, this is my next slide, here I bolded or put in blue trusted relationships. So initially what is going to matter the most is that your focus is building trusted relationships with the primary care providers in your community. Many of them are going to have had experiences with the big hospital, with other providers in town, and they're going to be very suspicious of yet another effort to reinvent healthcare. I'd encourage you to think about taking the steps as slowly or as fast as you can to build or rebuild those trusted relationships, because those primary care providers are going to be absolutely essential in the success of an Ontario health team. And as that trust develops, you can help them make informed decisions about signing up with the team. At the end of the day, it's a voluntary choice on their part, and you have to help them understand how this can make their work life much easier and really make a big difference in the lives of their patients. Because instead of the patients just having them to turn to, increasingly, as you heard Rob say, these patients will be offered in-reach services when they interact with the system, outreach services so they'll be reconnected. There'll be more people able to wrap services around them that complement what the primary care provider can do. The next one is maybe a bit more for future reference. It's not priority number 1 if you're a team in development or in discovery, but keep in mind you'll hear talk of collaborative governance. So what we currently have is a bunch of independent boards each of them trying to do the right thing but for them, for their members, and for whatever their community is that they serve. The future with Ontario Health Teams is all these different boards trying to figure out how do they make collective decisions together in a way that is deliberative, consensus-oriented, and directed to achieving a common goal. So in the past, the hospital had a particular goal or set of goals. The primary care doc wanted to do certain things. Now they're all trying to get on the same page to try and move the needle in care experiences and health outcomes while keeping costs manageable and making sure providers are engaged and supported. So just briefly, 3 steps for when you get to that stage. The most important, though, one is the final one, the trusted relationships. So I've already alluded to the fact that every community will have its own history about how people have interacted and treated one another in the past, but this is important to work through to build those relationships. So on to the OHT Central Program of Supports, the last set of slides. So I'm just going to turn it over to Karen Liu from the Ministry of Health, who will briefly describe the program in general, and then I'll come in and talk about RISE's role within that.
Thanks so much, John, and good afternoon to everybody here. I'm really delighted to be here with everybody here today, and I also have some ministry colleagues online as well with you at this first RISE regional session for teams in development, in discovery, and also other groups who may have not placed themselves yet on the Ontario Health Team's readiness path, but are considering it. So welcome to everybody. Before I jump into this slide and give you a brief overview of the central program of supports that the ministry is building to help teams, wherever you are on your readiness path, I just wanted to recognize the tremendous expertise here that we have in John, Rob, Jeremy, who is not here today, and the rest of the RISE team in creating RISE as an anchor resource in the supports program and a dedicated one for Ontario Health Teams. We encourage everybody to come to RISE often to seek the supports that you may need, because it will continually evolve with input from you as we hear more about what teams are needing in order to be successful, and particularly for teams in development, what you need to sort of move on to that next stage in the readiness assessment process. More important, I'm really excited to hear from you today about what you need as we're continuing to work to expand this program, and want to thank you for your engagement and your commitment in helping us work towards a more integrated health system. So in terms of the central program of supports, we've heard from expert stakeholders and providers on what it would take to implement the Ontario Health Team model. And through these discussions, we've identified a number of key principles that are at the foundation of the program that we're building. First, the supports program is grounded in the Ontario Health Team model, and the supports that are provided will focus on helping teams acquire the knowledge and build the competencies aligned with the components of the Ontario Health Team model as set out in the Ontario Health Team's guidance document. So RISE, and what John has spoken to earlier, has organized the supports in terms of the 8 building blocks, which are aligned with the 8 components of the OHT model as set out in the guidance. We're also building this program to meet teams where they are in their readiness. So each team, whether you're in development, in discovery, and full application, will all have different strengths and challenges. Through your ministry's point of contact, if you have one as a team in development, we'll have a way to understand how you need to be supported. But certainly teams in discovery will also benefit from the supports that are available through the central program. The program will also be end-user centered and co-designed where possible. We want to make sure that the supports provided are useful and actionable by teams. As we continue to expand our offerings, we'll be seeking to get your perspective on what works and what doesn't. And to that point, the program will be iteratively developed and continuously improved. And emphasize that we're just at the beginning here in terms of this program that we're building, and we want to work with you to improve and expand the supports offered. The program will also feature a mix of general and customized supports to teams. So what you'll find is that what's available right now are a variety of general supports that have been proactively made available to you. But as you progress in implementation and maturity, the supports that you'll need will become more specific. And through the program, we'll work with you to offer both types of supports. We are also approaching the delivery of this program through a number of core principles. We want to deliver it through a coordinated mechanism within the ministry. So we understand that there are many partners and many hands that are needed to successfully deliver this program. And so the ministry's role here will be to coordinate these collective efforts and to make sure that each partner is delivering the type of support that they are best suited to, and that the ministry is facilitating a team's access to the supports that they need. And we're bringing many partners with many different areas of expertise and experience within defined areas of support to work within a collaborative network to deliver supports. There's no single organization that can deliver all the supports that are needed for Ontario Health teams to be successful, and that's why we're bringing together the best experts to help teams. We want to provide equitable access to teams in terms of supports and to be able to offer through this program valuable resources and supports at no cost to teams. And finally, the supports delivered will be available through various modalities. Again, we want to hear from you about how you want to receive the information and supports and what's going to be most useful to you and actionable for you. I've just listed a couple examples of the types of modalities: information, guidance, tools, checklists, webinars, communities of practice. But again, I want to hear from you on what's most useful. So I will now turn it back over to John.
Thanks very much, Karen. So quickly on RISE, some of you may have heard this at the webinar that the ministry organized on Wednesday. I'll just be brief. The most important point on this slide is the last one, that are right now there are a ton of resources that are going out, some specifically targeted OHTs, others that are general and might be relevant. It's like drinking from a fire hose. What we're trying to do is give people the information they need, given where they are on the readiness path, in a form that they can use. So we're trying for that drink from a glass rather than drink from the fire hose. What our vision is on the RISE front is a rapid learning system that continually ups its game in achieving the quadruple aim that I talked about before. And that applies both at the provincial level, but every team is essentially now creating its own local system that needs to achieve the quadruple aim. And no one's going to get it right away. We're all going to learn and improve, and we're going to learn from each other about how to do it well. Our mission is to contribute to the OHT central program of supports by providing timely and responsive access to Ontario-based rapid learning and improvement assets. We're blessed in this province with an incredible array of folks that can add value to teams, and what we need to do is figure out how do we channel them in ways that get them to the people who need them. The ministry has been very clear from the beginning that it wants equitable access to support. It shouldn't matter what part of the province you're in, whether you're in a well-resourced or a less well-resourced organization. Teams should all have equitable access to support. So we're very committed to that. And on the flip side, we want to make sure that those people that bring rich experiences to the table have equitable opportunities to contribute. So if you were part of a bundled care project in a smaller community in Ontario, you'll have a lot of insights that other people could benefit from, and we want to make sure that people hear about those insights. The objectives quickly. Karen mentioned already the kind of proactive packages of support. You're part of the very first regional session. We have webinars coming up that start soon. I'll talk about them in a minute. We'll deliver on demand other activities and products. So if there are webinars that you think would be helpful, if there's a RISE brief that would be helpful, if there are other types of products that you think would be helpful, we're all ears, and you can communicate that through the ministry, and that will get passed on to us and other participants in the central program of supports. We're also building and engaging an OHT community of practice among teams on an OHT readiness path. In the next few months, until the October 9th deadline for teams to submit their full application, we're focusing on the issues that are particularly relevant to them. So you're welcome to join the community. We just want you to know that in these next few months, we're very focused on those particular challenges. All the issues that are going to come up are directly relevant to you. It's just that there might be some additional issues that are very relevant to you that might not be front and center in what that community is focused on right now. But we have other ways that we can meet those needs in terms of conversations than through that. But we strongly encourage you to join because you're on that path, whether or not you have an October 9th deadline. We're also setting up a complementary community of practice. This one we call the RISE community of practice. This is the people who are well positioned to provide support to you. So if you or someone who you know are able to help teams because you're great at data analytics, because you have great experience with patient engagement, because you've got a long history of working with Indigenous communities, then we encourage you to join that RISE community of practice so that we can better connect you to teams that could benefit from that expertise. We have a website, the English version, ohtrise.org. The French version, ESO, is Équipe Santé Ontario. That's the French language wording of Ontario Health Teams. We're going to have our first monthly newsletter come out this month. I'm going to talk about the types of resources that we're making available through that website in a minute, but it's not just RISE, it's anything out there that we think might be helpful to teams. If you go to the Key Resources website, a web page, you'll find 13 RISE briefs. I have a slide coming up in a few minutes that is specifically which ones to focus on if you're a team in development and discovery. You're, of course, welcome to use anything as you see fit, but I've zeroed in on ones that might be particularly helpful. And I should have said at the beginning, Carrie has said this in the online platform, the slides are available for you, so you'll be able to download them from the events webpage on the OHT site, and you'll also be able to access a recording of today's webinar. The three that are underlined because they're kind of part of a package, and they all link out to the same summary sheet. So for population health management, if you want a two-pager, that can be linked to from any of those three documents. Every RISE brief has a box in the top right corner on the cover page that talks about how it links to the building blocks and how it links to the full application. What matters to you right now is the building blocks, but when you move on to the stage of the full application, the connection to the relevant section or questions will help you. If you go to the All Resources webpage, you'll see the 8 building blocks. I've expanded here the 4th one. That's about integrated care. That's where the population health management comes in. And you'll see that there's an example of a resource in each column. So for integrated care, we have RISE Brief 6 about population health management. We have practice guides on implementing integrated care that come from the Health System Performance Research Network, which is another part of the OHT Central Program of Supports. And we have the Ministry's jurisdictional scan of select integrated care systems. In areas where we don't yet have an OHT or other partner resource, you can click on a link and get the best synthesized evidence in the world through health systems evidence. So it will pull up available research evidence on the topic. This is a quick summary for teams in development and discovery about things you might want to read first or do first. So think about reading the RISE brief about OHT building blocks. It has an Excel file that you can use, manipulate if you find helpful. You can read the RISE briefs to address specific areas of feedback. So if you got any feedback from the ministry and that feedback spoke to you need to have more clarity about how the leadership of this is going to work, that brief might be helpful. If you got feedback about the need for primary care leadership and engagement, that brief might be helpful. And then I'd encourage you to continue on the path that you're on, planning for how you're going to design the 8 OHT building blocks and how you're going to harness them to achieve specific targets. And when you get to that thinking, the RISE brief on population health management is going to be helpful. The other thing you can do is join events profiled on the RISE website. So we'll profile our own webinars, but we profiled last night an OMA webinar, Ontario Medical Association webinar. There's a lot of webinars coming up that are going to be helpful to you, and you'll find them all through the join events part of the website. We'll have a series of 6 webinars coming up, RISE webinars, that will dive deeper into topics that are likely to be very relevant to you.